Hi, I'm doing my final video for Nursing 7525 Program Planning, Management, and Evaluation by Catherine Bowman. Pre-program planning. Now, I kind of want to, as I show you what I have learned this semester, I kind of want to start with from the beginning, before starting this class, where I was at. I have looked back at all my assignments and picked out some things that I'd like to kind of talk about. So, in the first week's discussion, I talked about the planning, developing, and implementing process I feel okay about. It's the evaluation part that I struggle with. I look forward to diving into this process. Now, at the beginning of the semester, yes, I agree with this, but I don't think I really understood what program planning meant, especially, I know this kind of focuses on community health. That's kind of the aspect that I see it from. The whole planning, developing, and implementing process is way more scientific based and structured than I thought it was in the beginning. And so that's just one insight that I noticed. I also said, since starting last semester, I've greatly expanded my vision of what this degree can provide to the world. I'm talking about DNP degree. With more education and knowledge comes more responsibility. I know it's cliche, but I strongly feel this way. Thus, I am excited and open to seeing where this program leads me. In week one, reflection. When I was doing that, I had no established clinical immersion, and so kind of a little bit lost. No project, program, or plan in mind. And so I was just kind of exploring some different options, looking at CNA, looking at long term care, and looking at this dental program that I ended up choosing. So, first of all, Freedom Riders, I want to say that was really inspiring. I'd seen it before, but um, after after watching it and thinking about diversity and everything like that, I looked at CNA education in Utah and the process, and I see several relevant diversity and disparity aspects. First of all, that the CNA certification exams are currently only provided in English. Um, I think it also puts responsibility upon my shoulders as well. I have been blessed with incredible opportunities, and now I need to use what I have to help better the lives of those who are not as fortunate. And I feel like this class has really helped me kind of think about and hone in on some things that I could do. And looking at CNA education and testing, what are other aspects that may be causing disparities? There may be other things I don't see or know about because of my position and experience in life. I hope that through my immersion hours this semester, I will become more culturally competent and aware of how I can influence change where it is needed. I'm not going to come back to this, but I have thought about it as a scholarly project. However, the opportunity I had to help review some of the CNA questions, they've already got something in the works. It might be a possibility I can help, but it also might be something that I don't even have a chance to be a part of. But realizing that and exploring that a little bit more, I look forward to some of these things that should be coming out from the company that does the CNA test. So, all right, on to the community health assessment. Okay. At this point, I had chosen my topic, which is the pediatric dental health. I pulled a lot of quotes from these assignments because I think they kind of show a lot of different things in my progress in this course. One way to combat this health disparity is through a combination of school-based sealant programs, utilization of community health workers for education, and state policies to fund these programs. I pulled this idea from my policy class last semester, and that was the initial idea: school-based sealant programs, the community health workers for education, and state funding and stuff like that. So that's kind of how I started off. We aim to work collaboratively, so I kind of had this idea of what I wanted to do to increase access to dental prevention methods, develop healthy lifelong habits, and decrease health disparities and decrease healthcare costs through community-based education and programs. So that's where it kind of started. In the minority groups in Utah, specific social determinants are directly related to children's poor dental health, low income, lack of education, and lack of the health care. Low income or dental care, lack of education and health literacy leads to lack of knowledge on preventive care. Without health insurance, there is no preventive care. Even with insurance, dental services are underutilized in this population. I like to look at this because this is before the model comes out. I struggled with the model, and it's probably just because it's a new process and way to think. But I like to look back at some of these previous assignments and see that my mind was already there. I just didn't know where to go and what direction. So when we talk about the Chickasaw Nation program, this was my first thoughts about this project are the nursing process and the program planning. Someone recognized that there was a problem and then did something about it. And this, I think, was the first hands-on experience with program planning and evaluation and looking through that. And so I appreciated that experience. Now we get to the causal theory. I struggled with this, going through this. It was a good struggle, though, because I feel like I have learned and grown through it. So in the beginning, I was reading the book and I wrote a causal theory as it helped me understand my model better. And I used the book to create this. So risk of dental caries among children in Salt Lake City is indicated by high rates of untreated dental carie rates and is caused by poor dental health, lack of prevention measures, poor diet, and lack of access to dental care, but is mediated by access and utilization of dental care, education, knowledge, and use of preventive measures. Given that positive modeling behavior, good education, and cultural attitudes towards prevention prevail, access and utilization of dental insurance, care, and other available resources for prevention, and no comorbid or other genetic factors contribute to the problem, and good nutritional status. All these factors moderate the causes, and that children with poor dental health who have teeth in low-income households exist prior to the cause. That is how I was able to process this causal theory. And I think especially after going through it and honing in on some things, I could probably go through and fine-tune it, but that's my initial causal theory. So in developing a problem statement, every assignment and every aspect of this course, I learned something new. So in developing this problem statement, why do so many children have poor health, oral health? There needs to be more preventive care. Why is there a lack of preventive care? Because preventive care comes from access and utilization to dental care and the ability to pay for dental care. And I believe that this causal model, this process model, these effect theories helped me focus on what the problem is, what's causing it. I still struggle between, is this a mitigating factor or a moderating factor? Does it actually fit here or here? And I think sometimes it can fit in lots of different places. That's probably the struggle that I have with this model and theory, but I still find it very, very valuable. So the oral health program suggests, and I didn't put this one in parentheses, but it should be. The oral health program suggests that collaboration between dental providers and pediatricians could help bridge the gap between access and utilization of care. This vulnerable population is more likely to see their primary care provider before they contact a dentist. From the health problem perspective, this collaboration could be vital to decreasing disparities in dental health in children. This is where this idea of this collaboration between the pediatrician and the provider and the dental provider kind of came into play. It was doing my research and developing a problem statement. And so I kind of built upon that. Program objectives and goals. This is actually where the biggest aha moment came into play for me. Because I was trying to come up with specific objectives and goals, and I'm like, I don't really have a program. I have this idea and what I want to do, but I don't really have specifics. And so the idea came to focus on a specific age population. So first of all, focus on a few pediatricians' offices or one or whatever that serve Salt Lake City, specifically Medicaid patients. The population 6 months to 3 years who are seen at the pediatrician's office. And the intervention is establishing a system to connect the children to their dentist at the pediatrician's office at benchmark office visits. And through this, I was able to develop these objectives and goals. And so it was a really exciting time for me to kind of see how this big theoretical process and theory kind of is honing in. I'm like, oh, okay, this is the idea. This is the great idea. And so using that, looking at the effect theory and the process theory, again, the model, very difficult to work through, but going through it, doing these activities really help. I felt a little lost on this one as well. I'm having a hard time grasping the entire concept of the effect and process theory, but this is what I came up with. It helps to see everyone else's examples, and it's easier for me to grasp when I can see several examples. For me, I like to have things structured as much as possible. I follow that pretty well, and so having examples is really, really helpful. So looking through, this was a discussion, looking through everybody else's examples helped me be able to come up with my interventions and how that affects the effect theory, and then my process theory, and how the inputs, outputs, service utilization plan affect the interventions. So that was very helpful. Budgets and implementation evaluation. This is such a foreign concept to me. Probably the biggest takeaway from this was on this discussion, I said it was very helpful to have Dr. Hoffman explain some of these concepts with her experiences. I don't have any experience in this, and it's a little overwhelming and hard to conceptualize. This has been a great exercise to hypothesize a program and review all aspects of it. My hope is when it comes time to put this information to use, I will have a large amount of help and support as I learn how to project manage. So I thought that was very helpful. Quality and fidelity, also a struggle. It's a hypothetical program. Some concepts are hard to grasp. I'm having a hard time defining quality versus fidelity. I think some other students also struggled with that as well. I was hoping that the book would have a little bit more specific. It kind of describes quality as a minimum acceptable requirement or standard. I'm assuming that refers to the system process when describing quality and improvement projects. So a little bit of struggle there, but I hope I was able to get through that one. So now we go to the effect evaluations. So looking at the effect theory in terms of variables helps determine what can be measured to determine if the intervention produces the behavior change. So this is where you're looking at, is this program actually making a difference? And so the whole concept, again, it was difficult for me to look at the different dependent versus the independent variable. I'm very grateful I just reviewed my stats class last year during this, and that helped me kind of and I'm going to mess it up right now because I have to have something in front of my face to look at, but what is affecting your intervention. Okay, sorry. I'm trying to process this. This is how my brain works. It's really hard, but it's okay. I'm just going to move on at this moment. Okay, measures used to evaluate behavior change are so these are the measures that I want to use: the pre and post survey of current access, utilization of care, and current knowledge of and practice of preventive measures. These measures will not prove that the intervention caused behavior change, but will show a correlation. The behavior is now different after the intervention, even though this does not directly measure decreased dental caries in the population. These measures support the effect theory that the implementation program correlates with behavioral change. Okay. So I loved going through that and being like, okay, the different evaluations. It's okay, you don't have to have the most rigorous evaluation to prove that your intervention is actually working, that this is enough. And I think when I go forward just a little bit. So this is with the variables, the independent versus the dependent variables. This is where I get confused, and I'm like, the independent versus dependent, okay, this variable is dependent upon whether or not the intervention happens. That's how I have to think about it. So dental caries, does it happen? Does it not happen? It's dependent upon access to care, dental preventive measures, and the interventions. So those are the independent variables, but the dependent variables are the actual outcomes. So that's what I was trying to say earlier. So this, the effect evaluations with the variables, was able to help me process that and look at that. Also, this was also another aha moment when I was looking at different ways to evaluate effectiveness and looking at specific data. So patients coming in for well-child office visits are enrolled depending on the parent's choice to participate. Quantitative questionnaire assesses knowledge, behavior, and dental care access before the pediatrician's examination of the child. Motivational interviewing may be needed to fully assess knowledge and behavior, as a questionnaire might lead to response bias, which I'm pretty sure it would. However, the program intervention happens during the office visit, and then post-intervention survey occurs at the next follow-up visit, most likely in the next 3 to 6 months, because these children, 6 months all the way up to 3 years, are going in, or they should be going in to see their pediatrician at least every 6 months. And so this gives, initially my first thought was send out a pre-survey and a post-survey, but to get better response, why not do it all within the office so that you're getting that pre-survey before they go see the pediatrician, and then when they make their next follow-up appointment, then you're following up with access and knowledge. So that was another really huge aha moment for me, that I was like, okay, if this ever does happen, this is what I would do. And it would be convenient, but it also, again, not the most rigorous information to prove that your program is working, but it does support that effect theory, and the hope is that it would actually make some changes. And so and that also brought me to the thought that, well, once you get to 3 years of age, they only go in yearly. So if we lowered that threshold to 2.5 years, then if they come in for like their 2.5 month checkup, then by 3 years, that 6 months later, then you get all this data, and you can do it for 6 months, and you don't have to do it for several years, and then you can have some kind of monitoring. I don't know. It was just a very interesting realization of how everything is kind of worked together, and that if I were to go forward with something like this, that this whole process theory, system thinking, that's the big thing, is thinking of it as a system versus thinking it as of, oh, this would be good to do. It's the science behind it that this class has really helped me understand a little bit more. Oh, and then the goal is to adapt one or more validated questionnaires, and I think there would be some options to look at that as well. And I have a double slide. All right, updates and evaluations. So obviously my program is hypothetical, nothing else to report. However, this was the discussion last week. I felt like I had some great insights and thoughts from these past few weeks. The assignment on the evaluation sampling have helped me critically review my hypothetical program. And I've talked about this, but through the program, though the program might never occur, has helped me see important considerations I've not considered. Defining the type of evaluation makes me realize how important all the details are. If I were to prove that my program caused behavior change, a more rigorous outcome evaluation is needed. However, showing that the program decreases dental caries in children would be difficult to measure, so an outcome assessment is a more appropriate, cost-effective, and convenient evaluation. In other words, a more realistic evaluation. The pre-post surveys can't show the program causes decreased dental caries, but it can support the effect theory, meaning there is a difference happening and it is affecting change. So, biggest takeaways from this course is, even though it's been a struggle, that struggle has helped me see things from different perspectives. It's helped me change my way of thinking into system thinking versus whatever I was doing before, and the process and the science behind program planning, evaluation, all that. I have really enjoyed this, and it has helped me, and I know that if my wherever I go, my scholarly project or wherever I end up, and I'm looking at the things that I'm already doing at work for like the surgical center and looking at some of these other things and being like, okay, maybe this is not working because I'm not doing it appropriately, and having this plan and having this process set up. And so I'm hopeful that that will help me utilize this immediately right now and figure some things out. But really, really enjoyed this class, Lisa, and you were great. And I want to get into some more self help for myself in far as how to take care of myself. And I would be interested in some other things. I need to go back and look at that app you talked about, like the pressure points and all that fun stuff. But thank you so much, and it's been a great pleasure to do this, and hopefully I can escape this without doing anything else. Have a great day.